We start,
Dr.
sir.
Ramakrishna, medical and
Okay.
oncologist
So,
in medical
good
oncology.
evening to all.
So this is the case
To
which
I
was present
just
in the
sharing with you the
65-year-old male patient who is a diabetic and hypertensive, well controlled.
hello.
Yes.
Am I audible? Okay. Can we restart now? Tech team, please cancel it.
Yes, sir. Please start.
Do it restart. Huh? Okay. Okay. Please do the countdown.
Please start, sir.
Okay.
Okay,
Okay.
so shall I
Fine.
start?
Sure, yes. So, sir, let me introduce Dr. Rajiv Lochan Jina. Sir, he is from NSCRI Hospital. He's a medical oncologist, and Sir will be giving talk on reaching new heights in MHSPC care. With this, I would like to request Rajiv sir to start.
Okay, so
So,
my topic for today is reaching new heights in metastatic hormone sensitive prostate cancer care. Next slide. This is my disclosure. Next. So, patients, those who are diagnosed in a localized or locally advanced prostate cancer, they have biochemical recurrence later on, and they later on progress to primary progressive metastatic hormone sensitive prostate cancer. And also, we may have newly diagnosed metastatic hormone sensitive prostate cancers also. So, after giving them ADT, they progress to CRPC, that is castrate resistant prostate cancer, which can be non-metastatic or metastatic CRPC. And metastatic CRPC is a terminal disease which is followed by death. So the next slide. So the opportunity to delay metastatic CRPC and further improve outcome. So the stage where we can delay it is metastatic hormone sensitive prostate cancer. Next slide. So this is the Stampede control arm where only ADT was given, and here we can see the failure-free survival and overall survival. We can see the median event-free survival. It was 11.2 months, while median FFS was 11.2 months, and while as median overall survival it was around 3.5 years. So there is much chance of improvement here, as we can see. Next. Next slide. Next slide. So this is the Stampede arm where prostate radiotherapy was used, and we can see in less than 4 bone mets, that is low volume disease, the FFS and OS showed significant improvement when this radiotherapy was given. While for bone mets greater than equal to 4, that is high volume disease, it did not have much effect. Next slide. So the improving outcomes with systemic therapy, which have evolved over the time since 2013 to 2022, as we had many trials over where we can see docetaxel in trials like Charted and Stampede. We had abiraterone, which was seen in trials like Stampede and Latitude. And we have enzalutamide in Archies and Enjamet trial, apalutamide in Titan trial. Then we have abiraterone versus standard of care, where docetaxel was later added on as the standard of care in the PEACE-1 trial, and we have Arasens trial where darolutamide plus docetaxel was compared with docetaxel. Here we can see good hazard ratios, which is around 0.6 to 0.9. So there is a chance of survival benefit when we use these new agents. We now have a wealth of data supporting concomitant therapies. So what do we choose? Next slide. So this is the Charted trial docetaxel in metastatic hormone sensitive prostate cancer, and we can see that there is improvement in overall survival of 16.8 months in the high volume disease and with a hazard ratio of 0.63. So docetaxel, when added, it showed benefit only in the high volume setup, while in low volume disease it was not that significant because the improvement in OS was 0 months and the hazard ratio was 1.04. Next slide. This is the latitude, the abiraterone in high-risk metastatic hormone-sensitive prostate cancer. We can see the overall survival, median overall survival was 36.5 months in ADT plus placebo versus 53.3 in ADT plus abiraterone plus prednisolone. But this data has to be seen with a pinch of salt, because as we can see from the table on the right, we can see the prostate specific antigen progression. The median duration for prostate specific antigen progression in months, it was 33.3 months versus 7.4 months in the placebo plus ADT arm. But here we can see the subsequent prostate cancer therapy. If we see the ADT arm, the subsequent prostate cancer therapy was started, the median, it was 21.2 months. That is a 7.4 months, the PSA started rising median, and the prostate specific means treatment, it started 21.2 months. That is almost a 15 months delay in starting therapy. So this data has to be taken with a pinch of salt. Next slide. Okay, so here we can see even when abiraterone, just the previous slide, even when abiraterone was used at with prednisolone at a lower dose of 5 mg, we can see grade 3 and 4 side effects, like 23%, 22% patients had hypertension, hepatotoxicity was seen in 9% of the patients, and hypokalemia was seen in around 12% of the patients. Next slide. So side effect profile was as we can see with abiraterone. Now we have the Titan or the apalutamide study. Hello.
Yes, sir.
Apalutamide study, where we can see the even in low volume as well as high volume disease, the PFS as well as OS improvement was seen with significant P values. So it acted well in both low volume and high volume diseases. Next slide. This is the enzalutamide study, where we can see that the hazard ratio for overall survival was 0.67 and hazard ratio of progression free survival was 0.40, the p value being significant. But if we see the subgroup analysis, we can well see that low volume disease had a p value which was significant with a hazard ratio of 0.43. That is, it had a very significant p value in case of low volume disease, but not in high volume disease. Next slide. Next slide. So now we will go to the combination therapies. Next slide. We have the PEACE-1 study design, where they included de novo M1, and we can see that the patients were randomized into multiple arms, but the arms of our interest is the standard of care plus abiraterone plus prednisolone, to which later docetaxel was added as the standard of therapy changed over time. And it was compared with the docetaxel with the arm which had docetaxel. Next slide. So the PEACE-1 study, it was not designed to compare triplet versus doublet regimen, but what we could do is we can compare docetaxel plus abiraterone versus docetaxel here. And here we can see that in the high volume disease, the median, as we can see that the median OS, it was 5 point, sorry. So we can see that the hazard ratio here was 0.72 with a p-value of 0.019. So it was of benefit in the high volume disease only, while in the low volume disease, it was not significant. This led to a confirmation that in high volume disease, you could improve outcomes by adding abiraterone to docetaxel versus docetaxel alone. But in low volume disease, it did not show much effect. Next slide. Now coming to the ARASEN study design, which is a global randomized double-blind placebo-controlled phase 3 study. Here metastatic hormone-sensitive prostate cancer patients, they were seen and they were randomized to two arms, docetaxel plus darolutamide at 600 mg BD plus ADT versus placebo plus ADT with docetaxel. And the endpoints were overall survival and multiple secondary endpoints were also there. Next slide. Here we can see that 87% of the patients in this trial, they received all 6 cycles of docetaxel. And the adverse events between arms were almost identical. Next slide. Now coming to the overall survival, we can see that with the in the darolutamide versus placebo, the median overall survival at 51 months, it is 63% versus 50%, with a hazard ratio of 0.68 and with a significant p-value of less than 0.001. Next slide. So benefit was seen in all the subgroups, as we can see here on the right hand side, high risk patients as well as low risk patients. The median overall survival was 43.2 months in high risk patients with a hazard ratio of 0.71. That is almost a 29% reduction in the risk of death in high risk patient. And if we see low risk patients, here the hazard ratio of 0.62. The effect was more striking here with, as we can see, a median overall survival which has not been reached and a hazard ratio of 0.62. That is almost a 38% reduction in risk of death. Next slide. Next slide. So these are the other secondary endpoints where we can see time to CRPC. There we can see 64% risk reduction, hazard ratio of 0.36. Time to first subsequent antineoplastic therapy, 61% risk reduction. Time to pain progression, 21% risk reduction. And time to first SSE, it had 29% risk reduction. And the hazard ratio, as we can see in time to CRPC and time to first subsequent antineoplastic therapies, are around 0.3 to 0.4. Next slide. Now coming to the PSA response and outcome, if we see undetectable PSA levels, we can see that at any time it was 67.3% versus 28.6% in the placebo plus ADT with docetaxel arm. And next slide. So we can see that more than 2/3 of, next slide, 2/3 of patients reached below 0.2 in the overall study. The time to PSA progression, if we compare with PSA which was undetectable at 36 weeks versus detectable at 36 weeks, we can see that there was a significant difference in the time to PSA progression with a hazard ratio of 0.23. Next. And if we see if this time to PSA progression, it could be seen in the overall survival, yes, the difference was there with a hazard ratio of 0.37. That is, patients who had undetectable PSA at 36 weeks had survival benefit over patients who had detectable PSA at 36 weeks. So more than 2/3 of patients reached below 0.2 in the overall study. Next slide. Now, if we see the same thing for, hello, next slide. Yeah, if we see the same thing in patients with high volume metastatic hormone sensitive prostate cancer, at any time, the undetectable PSA, it was 62.2% versus 25.8%. And time to PSA progression, they had a hazard ratio of 0.20. Next slide. And it was also, the effect was also seen in the overall survival, where the hazard ratio of 0.30 and the median overall survival was not reached versus 22.1 months. So darolutamide triplet achieved long periods of no disease progression and also significant improvements to overall survival in the high volume setup. Next slide. Now in the low volume setup, we could see similar things. That is the undetectable PSA 83.8% versus 38.4%. Next slide. With time to PSA progression with a hazard ratio of 0.09, which is a very good result. Next slide. What we can see that time to PSA progression only at almost 4 years, the time to PSA progression, only 10% of the patients had progressed. Next slide. And for the overall survival, we can see similar results where the hazard ratio of 0.34 was seen. And there was a significant benefit in patients who had undetectable PSA over detectable PSA. Next slide. So, deciding between doublet and triplet in metastatic hormone sensitive prostate cancer, what things we have to consider? First, is patient is able to tolerate and accept docetaxel? Only if a patient is able to tolerate docetaxel, we will go with the triplet therapy. And the extent of disease, whether it is a high volume or risk disease, likelihood of hormone insensitive clones. Like if we are going for abiraterone docetaxel with ADT, it is the high volume disease. And if we are giving darolutamide, we can go for in the high volume as well as the low volume setting. And age and life expectancy hit hard and early because prostate cancer will be the cause of death. So the phase of prostate cancer which we will have to target is hormone sensitive prostate cancer. We'll have to see, will docetaxel be an obligation in the near future and much less effective? We can see it is much less effective post androgen receptor agent progression, and patient needs to be informed of the options. Next slide. Okay, thank you.
Thank you, sir. Thank you very much for this insightful talk. So,
Thank you.
with this, I would like to request Chanchal sir for his presentation. Let me share the presentation first. So, I would like to request Chanchal Goswami sir. Chanchal Goswami sir is medical oncologist in Manipal Hospital, and he will be giving talk on advancing MHSPC treatment horizons, darolutamide without chemotherapy. aeronaut evidence. With this, I would like to request Chanchal sir to start the talk.
Well, good evening, everybody. And
Sir, just yes, sir. Yes. Yes, sir.
yeah, please make it full screen. Yeah.
Mm.
Good evening, everybody. And thank you, Rajiv, for a wonderful talk. And thank you, Bias team, for giving me an opportunity to be over here. So today's talk for me is advancing metastatic hormone-sensitive prostate cancer treatment horizons. This is darolutamide without chemotherapy, the ARANOTE, and I'm going to present the evidence on behalf of that. As Rajiv has said, that not all candidates can tolerate docetaxel, and not all patients are suitable for docetaxel as well, especially the low risk, low volume disease. So this is the evidence what we can do without docetaxel, the darolutamide and ADT. Next slide, please. These are my disclosures. Next slide, please. Well, if you look at the standard of care for metastatic hormone-sensitive prostate cancer, which has evolved over a period of time to combine ADTs with AR inhibitors, abiraterone, and or docetaxel. So it started around 2014-15 with the CHARTED and the STAMPEDE trial, where docetaxel was very much a part of it along with ADT. Then it moved on to 2017-2018, where it was Latitude and STAMPEDE arm G, where abiraterone was added with ADT. And then came 2019, where enzalutamide came into the arena, which is with the ARCHES and the ENZAMET trial, where enzalutamide was combined with ADT, and enzalutamide with ADT plus minus docetaxel was given. Around the same time, TITAN came with apalutamide plus ADT. And then came the era of darolutamide, except in 2021, there was PEACE-1, which already Rajiv has said, which is abiraterone plus ADT plus minus docetaxel plus minus radiation. Then 2022 onwards till date, it is the darolutamide era, where darolutamide plus ADT plus docetaxel was there in the ARASENS, which Rajiv nicely presented. And my job is to present the data without docetaxel, that is ARANOTE and ARASEC, which is darolutamide plus ADT alone. So despite treatment with androgen receptor inhibitors and ADT or docetaxel and ADT, a large proportion of the patients with metastatic hormone-sensitive prostate cancer will eventually progress to metastatic castrate-resistant prostate cancer, and that too within 3 years of therapy. Next slide, please. So there is an unmet therapeutic need, and the unmet therapeutic need remains for an efficacious treatment that offers a differentiated and improved safety profile for patients with metastatic hormone-sensitive prostate cancer without adding significant toxicities and with low drug-drug interaction potential. The low drug-drug interaction potential platform is provided by darolutamide, and without significant toxicities is by omitting docetaxel from the treatment. So ARASENS, a phase 3 study, which was in combination with docetaxel, already showed beneficial efficacy and safety profile for metastatic hormone-sensitive prostate cancer, leading, can you make it full screen? Yes. Leading to its approval in India in 2023, and darolutamide in combination with ADT, which would provide efficacy benefit with a favorable safety profile in metastatic hormone-sensitive prostate cancer, as demonstrated in the global phase 3 ARANOTE trial with significant Indian patients. With the ARANOTE data, darolutamide has the potential to change the treatment paradigm, as now it would be the only ARI which would be used with or without chemotherapy, because we have the data from with chemotherapy in ARASENS, and we have the data without chemotherapy from the ARANOTE. And the most important thing, there is substantial number of Asian patients in this group, and that too patients included from India. Next slide, please. So the background is darolutamide plus ADT with docetaxel is the standard of care for metastatic hormone-sensitive prostate cancer. As I said, in the ARASENS, darolutamide plus ADT plus docetaxel demonstrated favorable efficacy and safety versus ADT plus docetaxel in patients with metastatic hormone-sensitive prostate cancer. And in ARANOTE, it was designed to evaluate darolutamide plus ADT versus ADT alone to provide a new treatment option for metastatic hormone-specific hormone-sensitive prostate cancer without docetaxel. Next slide, please. This is the randomized double-blind placebo-controlled phase 3 study where darolutamide 600 milligram twice daily plus ADT was randomized in a 2:1 fashion with placebo plus ADT. 600 odd patients of metastatic hormone-sensitive prostate cancer with histologically or cytologically confirmed adenocarcinoma of the prostate and ECOG performance of 0 to 2 were included in the trial, and the stratification was visceral metastasis assessed by central review committee as present or absent, and prior local therapy, yes or no. The primary endpoint was radiological progression-free survival, and the secondary endpoints were various with overall survival, time to initiation of subsequent antineoplastic therapy, time to CRPC, time to PSA progression, rates of undetectable PSA, time to pain progression, safety. Other pre-specified endpoints were PFS2, time to serious adverse event, and time to deterioration of FACT, P total, that is quality of life, and time to first prostate cancer-related invasive therapy. So there was an open level of double-blind phase of the study and open level phase, where in the open level, there was crossover was allowed. Next slide, please. The patient demographics were pretty well matched as far as age, race. You can see almost 30% patients were Asian. Asia also had 30% contribution to this, which is an important aspect. ECOG performance score, majority of them were ECOG 0, almost 50%, and 50% were 1 to 2. Gleason score more than 8 was around 70% of this patient. Serum PSA median range was around 20 in this group of patients. Metastatic at initial diagnosis, de novo were around 70%, and recurrent were 20%. Disease volume was high in 70% and low in 30%. Visceral metastasis was absent in nearly 90% of these patients, and the rest 10%, they had visceral metastasis. There was prior local therapy in 17% of the patient, and 80% of the patient did not have any prior local therapy. Next slide, please. This is the most important part of it. If you look at the country-wise representation, next slide, please. You would see that ARANOTE study has a good representation from the Asia-Pacific area with almost 16% patients from China, India, Taiwan, 3%, Australia 4%, New Zealand 2%, whereas the abiraterone study and the other studies had hardly any representation from the Asian zone, maybe from the Asia-Pacific zone, that is the Australian group of patients, but none from India. Next slide, please. This is the primary endpoint, that is the radiological progression-free survival, and you can see that the Kaplan-Meier is clearly showing a result in favor of the darolutamide plus ADT, where the hazard ratio is around 0.54, 70% median time to randomization. Median radiological progression-free survival is around 70% for the darolutamide arm and 52% for the placebo arm. Next slide, please. With a median follow-up of nearly 2 years. This is the subgroup analysis where all the criteria are in favor of the darolutamide arm, whether it is the overall population, age more than 65, less than 65, more than 75, baseline PSA value, more than median, less than median, ECOG performance 0 or more than 1, Gleason score more than 8, less than 8, high volume, low volume, race, white, Asian, black, and others, geographical conditions, Europe, rest of the world, Asia, Latin America, visceral metastasis, yes or no, and prior local therapy, yes or no. So irrespective of the criteria you choose, the primary endpoint was in favor of the darolutamide arm. Next slide, please. Next. Here, both the volumes, low volume, high volume, was in favor of the darolutamide arm. This is again the overall survival, which is the secondary endpoints, was again in favor of the darolutamide arm. Time to metastatic CRPC, time to PSA progression, time to initiation of subsequent systemic therapy for prostate cancer, and time to pain progression. All these criteria were benefiting the darolutamide arm. Next slide, please. This is the Kaplan-Meier for the secondary endpoints, time to metastatic CRPC. And you can see that the median hazard ratio was 0.4 in favor of the darolutamide arm in terms of metastatic CRPC, time to metastatic CRPC. For the darolutamide arm, it was not reached. The median time was not reached. Whereas for the placebo, it was 13.8. Time to pain progression, again, it was the median time to pain progression for the darolutamide arm was not reached. Hazard ratio was 0.72, whereas for placebo, it was 29.9 months. Again, both these secondary endpoints were in favor of the darolutamide arm. Next slide, please. This is the PSA value during at any given point of time, and you can see that the green bar holds for darolutamide plus ADT, and 62.6% of this patient had low PSA, undetectable PSA at that point of time. And if you look at the time to PSA progression, again, the hazard ratio was 0.31. For the darolutamide arm, it was not reached, and for the placebo arm, it was 16.8 months. Again, on these two factors, it was in favor of the darolutamide arm. Next slide, please. This is for the high volume and the low volume, and you can see the blue bar represents the darolutamide arm, and you can see there is a significant difference between the darolutamide arm and the placebo arm, starting from 24 weeks, 36 weeks, 48 weeks, and at any time, it was in favor of the darolutamide arm, both for the high volume as well as the low volume disease. Next slide, please. Subsequent life-prolonging anti-cancer therapy, if you look at it, patients who discontinued study treatment, nearly 70% of them discontinued in the placebo arm, whereas 45% discontinued in the darolutamide arm. Patients with subsequent life-prolonging systemic antineoplastic therapy was 32% in the darolutamide, whereas 42% in the placebo arm. And the subsequent therapies were either docetaxel, abiraterone acetate, enzalutamide, apalutamide, cabazitaxel, radium-223, olaparib, depending on the situation which was there. Next slide, please. This is the time to treatment-related adverse event, which is any grade, which is 91% in the darolutamide arm and 90% in the placebo arm. But grade 3-4 was subsequently equal in both darolutamide as well as placebo arm, and grade 5 was similar in darolutamide and placebo arm. Serious adverse events were also similar. Treatment-related adverse events leading to permanent discontinuation for darolutamide and placebo, 9% in the placebo arm and 6%. Median treatment duration was 24.2 months for darolutamide compared to 17 months for placebo. And the safety profile of darolutamide in ARANOTE was independent of the PSA response and consistent with the favorable tolerability first seen in ARAMIS and then subsequently in the ARASEN study. Next slide, please. This is the usual adverse event chart for the darolutamide and compared to the placebo. There is nothing much to choose. Anemia was slightly more in the darolutamide ADT arm. Arthralgia was slightly more. UTI was there in the darolutamide arm. Back pain was there. And these are all grade 3-4 toxicities we are talking about. And nothing great except fatigue was slightly more in the darolutamide arm compared to the placebo arm. But all these were manageable toxicities as far as the treatment is concerned. Next slide, please. Next slide, please. This is again the rates of adverse events commonly associated with androgen receptor inhibitors. And you can see all these were nearly similar in both the arms for placebo as well as darolutamide. So what we can conclude is darolutamide did not add any additional adverse event in this entire population. Next slide, please. This is the darolutamide extended the median time to deterioration of quality of life, FACT-P, by 5.1 months versus placebo. And darolutamide is the first and only androgen receptor inhibitor to demonstrate clinically meaningful delays in pain progression and overall well-being. So quality of life, in terms of the quality of life, the hazard ratio was 0.76 in favor of darolutamide. So it has a positive impact on quality of life in the treatment of metastatic hormone-sensitive prostate cancer when combined with ADT alone. Next, please. This is actually the results which are being shown for the quality of life, and you can see the scale. Everything is in favor of the darolutamide arm, whether it is the physical well-being, whether it is the social family well-being, whether it is the emotional well-being, functional well-being, prostate cancer-related symptoms, bowel symptoms, and urinary symptoms. So everything fell in favor of the darolutamide arm. Next slide, please. So in conclusion, darolutamide plus ADT significantly improves radiological progression-free survival in patients with metastatic hormone-sensitive prostate cancer. Darolutamide showed a benefit across all secondary endpoints. Darolutamide was associated with a deep PSA response regardless of the baseline PSA. Darolutamide is the first and only androgen receptor inhibitor to demonstrate clinically meaningful delays in pain progression, overall well-being, including social, family well-being, functional well-being, urinary symptoms, and darolutamide has a favorable safety profile, and we know it has the least drug-drug interaction. So darolutamide, we can safely conclude, plus ADT without docetaxel should become an additional standard of care for metastatic hormone-sensitive prostate cancer. I would say especially for low-volume, low-risk patients. So for high volume, high risk, you have Erasmus, so you can add docetaxel. But for whom elderly patients, you feel that docetaxel might be little intolerant. And for those of low volume, low risk, I think darolutamide plus ADT becomes a logical choice as a first-line treatment for this group of patients in metastatic hormone-sensitive prostate cancer. Next slide, please. Thank you. I will stop at this.
Thank you, sir. Thank you very much, sir. On behalf of Bayer, I would like to extend my sincere thanks to Chanchal sir and Rajiv sir for such an insightful and engaging presentation. And your valuable perspectives on aeronaut trial has given a light on the learning form, as well as to appreciate your clarity, depth, and effort to bring such a thought in this presentation. Thank you very much, sir.
My pleasure. Thank you very much.
Thank you.
I think if there are any questions, I would be happy to answer. But if there
Yes,
are
yes.
not,
So I would like to request each and every one, if there is any question, can you please forward? I think, sir, there is no question as of now. There is no question in the chat box also. So with this, I would like to close the session now. Thanking you once again, sir. Thank you very much.
Thank you.
Thank you,
Bayer.
Chandra.
Thank you very much.
Rajiv,
Thank
sir.
you, Rajiv.
Thank you, sir.
Thank you very much.
Thank you, sir. Thank you.
Okay.
Bye, sir. Bye.
Thank you, sir. Good night.
Hey, short.